Okay, so I think we can start. Good evening, ladies and gentlemen, and I would like to welcome to the PUSEN Medical webinar. And this is an interesting webinar. It will be conducted around 1 hour. And it's a great honor and pleasure for me to be moderating this session. So the agenda for tonight is that we'll do an introduction to our eminent speakers. Dr. Wissam Khalid from Saudi Arabia. He will talk about the RIRS in large renal stone and challenges. Then we will stop for 5 minutes for question and answer. And then we will proceed with another eminent speaker from United Arab Emirates, Dr. Pandia, about the RIRS for stone more than 2 centimeters and its challenges and their beneficial use, the challenge between the disposable versus the reusable. Then we will have our question and answer for 5 minutes and the closing and the remark for the session. So I am working as a urologist and andrologist, endourologist. I am chairing the surgical department in Al-Wakra Hospital in Hamad Medical Corporation, Qatar. And it's an honor for me to be the moderator. Our first speaker is Dr. Wissam Khalid from King Fahd Hospital in Saudi Arabia. He's working as consultant urologist, endourologist. He is working quite heavy administrative work also as deputy head of a urology department. He's a resident training program director, and he's having a role in as a head of urolithiasis steering committee in Saudi Urology Group. Our next speaker, Dr. Pandia, is also holding as a head of a department of urology in NMC specialty in Abu Dhabi in UAE, and he's working as a consultant urology, and as I know, he is working as laparoscopist also as other interests. So I would like to invite our first speaker, Dr. Wissam, to share his slide.
Okay. Okay, can you see my screen?
Yes, we can. Please go ahead.
Okay. Okay, thank you very much for this nice introduction. And thank Dr. Shamsuddini and PUSEN for this nice opportunity to speak about this interesting topic. So let us start by the guidelines. What does the guidelines say? Stones more than 2 centimeters go with PSNL. But was it always this way? If we went back 10 years ago, we'll see that in 2010, PSNL was the first choice for stones more than 2 centimeters, and ESWL came as the second choice, while flexible ureteroscopy actually came as the third choice. But with the advancement in flexible ureteroscopy, that changed. PSNL came as the first choice, and for stones more than 2 centimeters as the second choice, the flexible ureteroscopy or ESWL. So we always say endourology is not all black and white. It's an interaction. We cannot have a certain rule that will follow all the time. So there no treatment fits all. There are special circumstances. Like, for example, if we have a patient with a 4 centimeter or 3 centimeter stone, which PSNL should be the first line of management, but the patient is morbidly obese or has anatomical variation like a horseshoe kidney, a pelvic kidney, spinal deformities, or bleeding diathesis, we cannot go with the PSNL as the first choice. We have to rely on other modalities of treatment. So what are the limitations of the PSNL? I love PSNL. I do a lot of PSNL cases, but sometimes there are some limitations that we face. For example, it be could technically challenging. Not everyone you have be well trained to perform PSNL. There are higher complication rate and more serious complications. There are many contraindications for the procedure, and as we all know, it always carries a longer hospital stay than RIRS or ESWL. So this is from the EAU. As we can see here, the paragraph dedicating the contraindication of the different endourological procedures. We can see a long list of contraindication with the ESWL and also with the contraindication of the PSNL. But here in the EAU, it states, apart from the contraindication of general anesthesia or untreated UTI, ureteroscopy can be performed in any patients without any specific contraindications. If we see the trend in endourology, here's a survey that we conducted, and it's going to be published in the Annals of Urology. We asked the urologists in Saudi Arabia, how much did the introduction of flexible ureteroscopy decrease your rate of PSNL? And surprisingly, more than 45% of the participants said that it reduced more than 20% the rate of their doing PSNL. So flexible ureteroscopy is really carrying on. So what are the advances that allured us to go toward flexible ureteroscopy? In 2004, there was the introduction of the flexible ureteroscopy with the impressive deflection of the 270 degrees in both directions. And after that, we had the digital flexible ureteroscopy with the impressive image. And in 2016, there was a breakthrough in the area of the flexible ureteroscopy with the introduction of the disposable flexible ureteroscopy. And earlier this year, we had the thulium fiber laser, which really might change the game in endourology. So if we want to look for in the literature, many studies compared RIRS with the PSNL. And here is a meta-analysis that came only earlier this year. They compared RIRS versus percutaneous nephrolithotomy, 4 stones more than 2 centimeter. 2 randomized study and 9 non-randomized studies were included for more than 1,600 patients. In their conclusion, RIRS is challenging PSNL for the treatment of large renal stones over 2 centimeter, becoming a safe and effective alternative with comparable stone-free rate and lower complication rate and lower hospitalization time. But you have always to tell the patient that doing RIRS for a large stone might carry the risk for stage procedure. You might do 2 or 3 times and able to be stone-free. But even when we see meta-analysis like that, we have to be skeptical to ask questions. Is this reliable or can we do it in real practice? So we have to admit that there are shortcomings of flexible ureteroscopy, especially if you compare it with the PSNL. It has higher cost, lower stone-free rate than the PSNL, and longer operative procedures if we want to do it for larger stones. And there are complications that are associated with higher intrarenal pressure and complications associated with thermal injuries for using lasers. So how to improve the stone-free rate? There are different factors you have to control in order to improve your stone-free rate, starting by choosing the right flexible ureteroscopy, choosing the right laser, and choosing the accessories, and choosing the right stone. And this is if I want to go with RIRS to treat stones larger than 2 centimeter, I put all of these into consideration. So Dr. Pandai will speak elaborately about the disposable versus reusable. For me, I always prefer disposable flexible ureteroscopy. Why? Because it gives you out-of-the-box performance in every case, no cost of maintenance, no need to wait for maintenance. We had the trouble earlier when we didn't have this disposable flexible ureteroscopy. If our flexible ureteroscopy was broken, we have to send it to Germany and wait for 2 to 3 months without flexible ureteroscopy. But now you can open a new one out of the box immediately. It's suitable for training centers. I remember when I early had my training, the flexible ureteroscopy was only for the consultant, but now even you can give it even for the R2 if you train him well, and it gives you freedom. You don't need to be cautious regarding deflection degree or the length of the procedure. You can do whatever you want with the deflection. Here's a picture was shared by my friend Dr. Said bin Hamri. You can see an impressive deflection reaching all calyces with a different difficult anatomy. And on the left side, you can see the double deflection. Even the hardest calyces, you can reach it with the flexible ureteroscopy. And you know, when the first flexible ureteroscopy came to the market, it was high priced, but I always say that diversity of options is in the favor of the consumer. Companies are starting to compete against each other, and this competition is actually in our favor. The prices go down, the quality goes up, the diameter of the flexible ureteroscopy goes down, and the vision improves in every scope. And by this, here's the new flexible ureteroscopy that just has been launched today by PUSEN. You can see an impressive 7.5 fringe shaft and diameter. We started the disposable flexible ureteroscopy with a 9.5 fringe, and now it came down until 7.5 for the shaft and for the tip. So what does the literature say about the disposable versus flexible? Better ergonomics decreases the risk of cross-contamination, it's cost-effective, and have a good flexibility throughout long cases. And now we're moving toward choosing the right laser. So until today, a home mammography is considered the gold standard for lasers. And there are advances every day in that area. Now we have whole mammography machines with variable pulse width, which means you have short pulse and long pulse. And I'll explain later what's the difference between those two and the benefit of each one. We have increased powers and frequencies, and we have the MOSES technology. So as we all know, targeting stones via laser, you can do it either by fragmenting, giving big fragments, which you later basket, or dusting to bring small particles of dust, which you can wash out through the working channel, or it goes down to the ureter. There are different studies trying to compare both. Each one of them has advantage. You have to tailor your way how to aim the stone, I think, according to the case that you have. And then we have the MOSES technology. This picture sums the idea behind the MOSES technology. It's MOSES parting the Red Sea. And this is the idea. In the MOSES technology, there's an initial bubble that creates a space parting the fluid, and then a second bubble, laser bubble is created, and that energy is transited through air. And theoretically, it's more efficient. We can see here in the regular one, the bubble collapses immediately, and down in the MOSES technology, there's the initial bubble and followed by a second bubble. And also theoretically, the MOSES technology decreases the rate of retropulsion, and so it increases the efficiency of stone dusting in the kidney or in the ureter. These are the different methods how you can tackle the stone, either in the kidney or in the ureter. But to sum up, if you're aiming for dusting, go for long pulse, low energy, and high frequency. And if you're aiming for fragmenting, go for high energy, short pulse, and low frequency. So again, for settings, for dusting, high frequency, long pulse, and low energy. And actually, these settings not only increase the efficiency of dusting, it also protects your laser fiber from backburn. But we have to know that dust, it's not a 4mm stone, it's not a 3mm stone. Earlier this year, Traxer group defined what dust is. They defined dust as less than 250 micron, depending on the floating and sedimentation. and the ability to remove all of this dust through the working channel of the flexible ureteroscope. But there's a new player or a new hero in town, the thorium fiber laser. Everybody is excited about the thorium fiber laser. What does it promise? It promises smaller fibers, higher frequencies, and lower pulse energy, lower power energies, and more dusting capabilities. But we have to say that all studies until now are not clinical studies; they're in vitro studies. Olympus just launched it this year, and maybe with the COVID situation, we didn't have the chance to really evaluate it clinically. But it has a high promise, as we mentioned, of these characteristics. In addition to having a small machine, no need for a big machine for fans to cool the system, and you can plug it in any electricity, not like the other laser machines. So here we come to the choosing the right patient. So this is a patient with a Staghorn calculi. Could we treat Staghorn patients with RIRS? So actually, there are several studies or investigating the role of RIRS in managing this kind of stones. Like this study, for example, doing staged ureteroscopic monotherapy, it reached the stone-free rate up to 82% in a 3-stage procedure. You can do endoscopic combined intrauterine surgery. We can do ureteroscopy followed by Reusable, or salvage ureteroscopy after PUSEN. Here's a picture. Here's one of our cases. This patient have a complete Staghorn in a double moiety. All moieties, both of the moieties are completely covered with stones. So we did him with endoscopic combined intrauterine surgery. We started with doing the lower pool, and afterwards we moved to the upper moiety. And the use of flexible ureteroscopy along with the PCNL actually speeded up the procedure, and it made us reach difficult calyces that we couldn't reach through the PSNL track, and we didn't need more than 2 punctures, and it makes sense in a case like this. So, as I mentioned earlier, if I choose RIRS for large stones, there are certain accessories I'd like to use with the RIRS in that matter. The dual lumen catheter, I like it because it has a tapered end. It's a hydrophilic coating and allows you to put contrast in the guide wire or 2 guide wires. And I use it to calibrate the ureter because, as I mentioned, it has a tapered end, which is started with 6 French and ends with 10 French, and it has a hydrophilic coating. So it's easy to put it, sometimes it's easier to put it before the access sheet just to calibrate the ureter. Irrigation is very important in RIRS. I use the Traxxer flow. You can insert your laser and basket, inject contrast, and use irrigation under gravity or automated pump, and use extra irrigation using the manual pump. So here's an interesting study by our friend Saeed bin Hamri. This was back in 2013. He was asking the question of which ureteral access sheet is good for your flexible ureteroscope. But this study was done like 7 years ago when we didn't actually have this disposable flexible ureteroscope. So back then they recommended the 1214 French ureteral access sheet as the universal access sheet that fits all scopes. But now, as we mentioned, the flexible ureteroscopes are going smaller and smaller in diameter. The first generation we have 9.59 and 7.8, and just today we have the launch of PUSEN, the 7-point French flexible ureteroscope. So we can really go down with the sizes of the access sheet. As an accessory, this is the Calera system, which was introduced in the World Congress of Endourology 2019. It's a stone aspiration device. They compared it with the basket in terms of stone-free rate, and they found that it has 85% stone-free rate in comparison to 58 doing the basket. So it's more efficient, especially if you're doing fragmenting. It's more efficient to use the Calera system than using the basket, but still it's under investigating. So now we chose the flexible ureteroscope and we chose our accessories. Is it safe to do flexible ureteroscopy for large stones? I think for sure there are some complications, and we have to plan how to avoid these complications. Intrarenal pressure is a very important issue and is a very dangerous issue. Studies report that during RIRS, the intrarenal pressure can range between 40 and 200 centimeter water, which increases the pyrovenous return and increases the risk of fever, UTI, and sepsis. And the thermal injury is an important factor also. Studies showed that without irrigation, tissue injury could happen even with 5 watt. So how can we avoid that? By using access sheet, by using ureteral access sheet, especially if you're aiming for going for a large stone. I recommend it to reduce why using ureteral access sheet usually remain the pressure lower than 30 centimeter water, and with a 40 ml per minute irrigation rate, it seems to keep the temperature low with the use of lasers up to 40 watt. But high power laser settings require high irrigation flow, but be careful for the intrarenal pressure. But we all know this famous study by Traxer showing that ureteral access sheet is not that innocent. Sometimes it carries a major risk in doing ureteric trauma, ranging from small mucosal injuries up to avulsion, and this is very dangerous. So how to avoid injuries associated with the ureteral access sheet? First rule, don't force, don't force, don't force. Some might advocate, and some famous endourologists actually, they measure the ureter caliber and calibrate it with a semi-rigid ureteroscope. Me myself, as I mentioned earlier, I calibrate the ureter with a dual lumen catheter. Sometimes if you don't have it, you can dilate the ureter with the inner obturator of the ureteral access sheet. Giving alpha blocker is controversial, but there was a study by Clayman last year. He gave alpha blocker for 1 week prior to ureteroscopy, and he found that giving alpha blocker facilitate even inserting the 14-16 French ureteral access sheet. So if I'm aiming, if I know that this case is going to be long and I'm using access sheet, actually I give them the alpha blockers. So the last thing, if the ureter is tight and you're planning to do RIRS for a large stone, it's not wrong to pre-stent the patient and bring him another day to do the flexible ureteroscopy. In conclusion, RIRS could be a valid option for large stones, especially with the other modalities are contraindicated or in difficult anatomies. Choosing RIRS could carry less morbidity and lower hospital stay, but might require multiple procedures. The possibility of stage therapy should be discussed with the patient. Available instrument and surgeon experience should play a major role in deciding which treatment modality. If you choose RIRS for large stones, respect the irrigation temperature and intrarenal pressure to avoid complications. It might be wise to use ureteral access sheet in long cases for the aforementioned reasons. The availability of disposable flexible ureteroscopy was a game changer for a lot of centers and might be the solution to avoid maintenance costs and long period of maintenance. The new advances in the field, like smaller ureteroscopes, the thulium fiber laser, might actually change the guidelines in the near future. Thank you.
Thank you very much, Dr. Wissam, for a very interesting subject and challenging, to be honest, for the big stones and how to manage it. I would like to ask the participant to use the question and answer box to post their question there so that we can open the session for the question and answer. So till we will get the questions, maybe I can ask the first question, Dr. Wissam, regarding those challenging cases, big stones. Are you regularly pre-stenting them before you tackle them with the flexible URS?
No, actually, I don't. I never plan to pre-stent. As I mentioned, I use alpha. If they're planning to do a RIRS for a large stone, I give alpha blocker. I try to dilate it with the dual lumen or the inner obturator of the ureteral axis sheet. If those tricks didn't work, then I'll put a stent and come another day.
But in those cases, if you manage to dilate, then what is the choice of what size of access sheet you will use? Especially now we know that we have other access sheet with aspiration, and I think this is a another revolution for the big stones that you can aspirate while you're working, so you will have a reduce the intrarenal pressure and sucking at the same time the stones. The vision will be better. And so what size you prefer?
Okay. Actually, we have four kinds. In my center, we use four kinds of disposable flexible retroscopy. So it depends on which scope I use. I always like to make space between the flexible ureteroscope and the ureteral axis sheet to allow for backflow through the ureteral axis sheet. So if I'm using the LithoView or the PUSEN, I go for a larger ureteral axis sheet like the 1214 if the ureter allows. And with the other flexible ureteroscope, I use smaller. If you can go smaller, I prefer smaller. You can go with a 10-12 as long as you have this backflow. But if you're using a large flexible ureteroscope, you have to go with the 12-14. But now maybe with the launch of this new flexible ureteroscope, which is 7.5, you can easily go with the 10-12 ureteral axis sheet.
Exactly. So you can have a better channel in order to have the better suction and, of course, having better division. We have a question saying that how exactly do you evaluate or measure the intrapelvic pressure while you're working? What is the uh, things that you will measure that you are happy on continuing, Dr.
Okay,
Hussam?
so intraoperative, it's hard to measure, but uh, to accurately measure it, these studies had special devices to measure the intrarenal pressure in different situations. But if you're using free irrigation, just by the height of the irrigation, you can somehow have a clue on how much you're going. So you can start with the 40 centimeter or 60 centimeter above the bed for the pre irrigation, and just use the pump when you need it, when the vision is not clear. Just gentle. I always tell my assistant, if I need an extra pump, just do a gentle pump with the two fingers, and that's it. And just only for a few seconds to clear the vision, and then I'll continue with the normal irrigation without pressure.
Yeah, just a comment here. I think academically, of course, there are ways of measuring intrarenal pressure with the sensor, but during the surgery, those ureteroscope doesn't contain any sensor. But
Exactly.
as you mentioned, those measures, especially the pump, the Traxer pump, and the fluid irrigation that you are using, and of course the time of the surgery is important
Exactly.
on deciding and reducing as much as possible the intrarenal pressure. We have another question is saying that what's your experience with a big stone more than 2 centimeter using the flexible ureteroscope, and are you using the reusable flexible URS too?
Actually, especially if I'm going for large stones, as I mentioned earlier, I prefer the disposable flexible ureteroscopy. You don't need to worry that your scope after a long procedure will go immediately for maintenance. And Dr. Pandaya, I think, will elaborate about this issue. Um, uh, my experience, yeah, for more than 2 centimeter, actually, I always go through the guidelines doing PCNL, but in special circumstances, like recently I had a patient who has a single kidney and she's diabetic and coming with the recurrent stone. So, and she came with a 3 centimeter stone, which is uric acid, associated with her metabolic syndrome situation. It was easily to dust. So for that patient, I went with the flexible ureteroscopy. But not all patients, I go, especially for stones more than 2 centimeter, I go for flexible ureteroscopy. Just selected cases. But maybe with the new technology like the thulium fiber laser and the small ureteroscope, we can push the limit and going bigger and bigger. And actually, the guidelines itself might change in the near future.
Yeah, probably. Yeah, the next question is for those bigger stones, since it is challenging. The question is, do you have any time limitation for your flexible URS?
Okay, this is a very good question. Um, Actually, you cannot find two endourologists to tell you the same answer in this regard. I always, we have these discussions, and even with the big endourologists who are famous for doing flexible ureteroscopy, like Professor Traxler or Preminger and Grosso, each one of them tell you a different answer. So for me, if I'm using a ureteral access sheet, I have the 90-minute time limit. I won't go further.
Okay. Then probably the last question is that the question is, you mentioned that there is ways to evaluate the size of the ureteric lumen. How this could be done?
Okay. So many are doing this trick of calibrating the ureter with the semi-rigid ureteroscope. And even famous endourologists, they start with doing a semi-rigid ureteroscope. And now we have, even for the semi-rigid ureteroscope, we have smaller and smaller sizes. It goes down until 8 French semi-rigid ureteroscopes. So they evaluated with the semi-rigid, and also in the same time they calibrated and dilated using the semi-rigid ureteroscope.
Yeah, actually,
and you can use,
one of,
for me, I use, as I said, the dual lumen catheter. I insert it through the ureteric orifice, inject contrast, and that gives me an idea about the entire ureter. And it has a hydrophilic coating, so I try to advance it slowly, and it's very gentle. Most of the time, it works.
yeah, I'm a big fan of this optical dilatation, it's called, and you will be surprised that you will see a piece of stones coming to the ureter that
Exactly.
if you push the access sheet, you might perforate, you might push the stone to the lumen. So it's really a nice practice. Thank you very much, Dr. Wissam, and
Thank you very much.
for this a nice presentation and nicely elaborated about the questions. Thank you very much.
You.
Now we will continue with our second speaker, Dr. Pandya. And Dr. Pandya, he will challenge even stones more than 2 centimeters. And what is the benefit of the reusable and disposable ureteroscope on those cases? So, Dr. Pandya, you can share your
Thank you.
slides. And again, I would like to invite all the participants to use the Q&A box for posting their questions after the presentation. Please, Dr. Pandya.
Give me a moment and I should be on.
Sure.
You can see my screen?
Yeah, we can see it. Just you need
So
to
make it, full
have
view.
a slideshow.
Yes. I need to just move this away and make this. Okay. Is it visible now?
Yeah, it's perfect, sir. Go ahead.
Okay, so let me go back to my first slide. So thank you very much for having me on this wonderful webinar, which is a topic which is provocative. And I'm glad I'm speaking after Dr. Wissam, who has elaborated lots of academic and theoretical points as well, which actually uh, I wouldn't want to, because I would talk about more the technical aspects and the practical aspects of doing the retrograde intrarenal surgery using uh, the right scope, I would say, not favoring reusable to disposables. In a specific situation, we can identify which one is better. So as from Dr. Visam's, and we all know this, we use the EIU guidelines very freely, and we know that it helps us medico-legally as well. So the primary choice for stones larger than 2 centimeters being percutaneous nephrolithotomy. But as Dr. Visam again showed, that the guidelines change, and there are reasons why the guidelines change. So if you look at the recommendations, they have said that the guidelines say that with flexible ureteroscopy, where the PNL is not an option, obviously the best way to go around is flexible ureteroscopy or shockwave lithotripsy. Here I would like to add a personal opinion as to the fact that for a larger stone, shockwave lithotripsy might be favored less. Increasingly, people are moving towards flexible ureteroscopy because of its visual nature and more direct stone targeting and cleaning as well. We can clean up the stones. So the discussion, as we know, we perform PNL, but shockwave lithotripsy, as I said, when the stones are very hard, when they are not to be supposed to be broken by shockwave, then laser, as of today, doesn't have a specific restriction. As of today, we can adjust the laser energies and break the hardest of the stones. It would be really very rare to find stones which not break. I'm practically in last more than 10 to 12 years where the lasers have been used, I have not heard of laser not being able to break the stone, whereas shock waves are not the best. Adding to the fact of more than 2 centimeters, when the guidelines say PCNL is not an option, RIRS obviously becomes an option. Any logical urologist who thinks logically will say that when there is a larger stone and lesser invasive procedure, like comparing PCNL to RIRS, the RIRS being less invasive, the chance of multiple procedures to get a stone-free status is more likely. Now, this was a very interesting article that I saw, and it explains why we moved from open or more invasive surgery to PCNL. So patients unfit for open surgery, energy delivery and intraoperative indications. They are talking about PCNL, miniaturized instruments, then evolvement of the intracorporeal lithotripsy, etc., etc. Now, this exactly fits in why, even for larger stones, RIRS becomes a good option for doing stones which are primarily currently thought of doing only by PCNL. So this is what the provocative nature of this discussion is, that why not challenge ourselves to be less invasive, and that is what the world is going towards, where we go less invasive. So Dr. Visam again talked about this regarding the PCNL and why I think RIRS can replace PCNL. Patients with obvious contraindications to PCNL, we are going to plan for RIRS. Most patients as well as endourologists will agree that PCNL is more invasive. Now, when you explain to the patient, when you talk to the patient, then he understands that PCNL has a puncture, you are going to put him prone and longer stay. So he understands the invasive nature, he or she understands the invasive nature of PCNL. We know the problems of the PCNL are quite a bit more as compared to RIRS. Additionally, we have lasers improvements, and I'm very glad that Dr. Visam touched all that. Access sheath, there is no question about it. The fact that when we use larger stone as to be treated with RIRS, so when we think of treating RIRS for a stone which is large, I would not go for a 10-12 sheath. we will explain, we will discuss that more. So 12, 14 becomes important. Ureteral calibration. So I'm going to cover this individual topics, and acceptance of stage procedure is for a lesser invasive procedure. Some patients just won't consent for PCNL. So PCNL as comparison, and then what are the reasons why we cannot do a PCNL. So technically not many contraindication exists for not doing a PCNL. So untreated UTI, obviously you can't even do RIRS. Tumors in the kidney, or maybe polycystic kidneys with complex cyst sitting here and there with stones which are larger. Challenging anatomy, that becomes a problem where the ectopic kidneys or pelvic kidneys. Renal cancer, you may be planning some procedure where you save the rest of the kidney. And then during pregnancy and the bleeding disorders, this was discussed. Most patients as well as endourologists will agree PCNL is less invasive, this topic. So PCNL is definitely more invasive. Bleeding can happen for no reason. Everybody who does PCNL, we know that whether it is ultrasound guided, whether it is fluoro guided access, the bleeding can happen. Sometimes you cannot find a reason why it is bleeding. Then when you go inside the kidney, when you do the nephroscopy, when you put your scope in, which is a rigid nephroscope, that is the time when you really see the calysis and the anatomy. So it might be surprising, or it might surprise you. Oh, I was expecting it to be more easier. And the fact that I would like to turn it this way, I would like to turn my scope that way, which doesn't always can be easier. So that is another reason. So RIRS has a good role there. Dilatation, access sheath, they are invasive steps. We don't know how narrow is the infundibulum, how narrow is the calyx, especially when we deal with smaller stones like 2 to 3 centimeters, when we deal with those stones for a PCNL. So the systems may be undilated. They are not very favorable for PCNL. And slipping out of the sheath. So you have to be dependent on your hands, the hands of the assistant who can hold the sheath well. Otherwise, the sheath keeps moving in and out while washing, while grasping the stone, and that removes the tamponade. So PCNL has its own problems. Now, improvements in lasers. This is one of the reasons why larger stones can be tackled with RIRS. So one thing very important is when you have the laser, you know what the laser is. Obviously, currently the gold standard is holmium YAG laser. And during use of laser, the two important things in mind practically is the heat dissipation and kind of the use of irrigation. So we will discuss that as well. So the access sheet all go together. It's a strong multifactorial thing needed to really get it effective. So larger stone, it is better to dust. And as the guidelines also say, dust and go rather than fragmenting, which is then difficult to really clear out. So dust and go is the principle. And for that, lays longer in time, as in the total time of the procedure. So you can, sometimes I extend up to 120 minutes as well, and using the laser intermittently. So you give a strong breaking dusting effect for maybe almost say 45 to 50 seconds or a minute, and then spend some time washing, decompressing, and let the particles come out, and keep on doing that. And I found success in doing that. At the same time, we use a pump which has a flow and a pressure control. Now, what does that do? While I am lasing the stone, my assistant, my nurse, would do a continuous irrigation or a pumped irrigation, which is a pump basically, which can be controlled. So I start it, I off it, I start it, I off it, depending upon the vision as well. So as I said, it is a multifactorial thing. Obviously, the correct laser fiber has to be used if it is reachable, because smaller laser fibers may not be able to deliver the right energy. So the right laser fiber, which commonly I find the 272 fiber or the 365 fiber better. Now, this is an important point to remember. It is a better thing to use a larger fiber when we use the disposable scope, so that the fiber related injuries to the sheath or the injuries to the scope are avoided. Use of access sheath. I think everybody reads literature nowadays. We are all enough communicating with through the internet. There is a lot of material to read, so that is why I'm not showing any references or per se, because everybody reads a lot of literature and we discuss these points. This is like a face-to-face discussion. We don't need to really point references, which I'm glad Dr. Wissam did a lot. So talking about access sheath, there is no question. Larger stone, better irrigation, longer time, simple. It reduces the intrarenal pressures, allows free flow of irrigation, which actually on the go washes out small dusts and facilitates entry and exit, because you can use the scope, and then with a pumped irrigation, when you stop the pump and if you pull the scope out, sometimes maybe completely out, then the turbulence effect brings a lot of stone material out. Using of access sheath, I am so very glad that Dr. Shamshoddini as well as Dr. Wissam brought up the issue of calibration, and I'm glad that optical visual calibration is one of the best techniques. So I use the 6.7.5 scope, then I use the 8.9.8 scope, and if I am happy by the entry of the 8.9.8 scope, then I put the inner sheath of the access sheath, and then reload and then put the access sheath. Finally, most of the times, visual impression gives you a good gauge. There is no way to really gauge whether you will be successful in getting the 12-14 sheath inside, which I prefer all the time. But yes, ultimately, it is your finger. It is this which matters the most, that you feel that you are injuring a tissue. Don't force. That is what Dr. Wissam nicely said. Don't force, because these fingers are the ones who know that when you are forcing, you are injuring something, you are cutting through something. And that is not what we want. If need be, yes, we cannot put the 8.9.8 scope, then we definitely, I put a stent, especially for the stones which are 2 to 4 centimeters when I plan RIRS surgery. These things can avoid the injury to the ureter. I like this particular set of serial calibrating ureteric catheters. I show the company as well, although I can say there is nothing to hide as a special company, nothing. So, but this starts from 8 and it goes up to 14. And this with a lot of jelly, and it helps to calibrate the ureter, and you can feel the feedback on your fingers that, yeah, it is going well. And if you feel that you can reach 12, you can reach 13, you can reach 14, obviously your 12-14 access sheath will go. One of the very important armamentarium in the whole multifactorial thing to be successful in this larger stone RIRS, 2 to 4 centimeters, is an use of an irrigation pump. So the irrigation, as we know, is used in very many techniques. Some people use handheld syringes, which are a little larger. There is the Traxxer pump, which is there. There are pumps which are automated pumps from various companies all over the world. So practically you don't do much, but the pump decides the flow. Unfortunately, none of the pumps, none of the techniques, anything, none can tell us what is the intrarenal pressure. And this is for one reason I always prefer using 12/14 access sheath, which gives me one solace that because the return is good, I'm not allowing the tissue inside to have an overstretch. Now, typically when we do a hydrodistension of cystoscopy, for whatever reason, or rather for sometimes we do the hydrodistension therapeutic, the petechiae hemorrhages develop. Similarly, when you go back inside, or if you have a lot of high pressure inside, one way of knowing is you will have a lot of petechiae hemorrhages developing during the procedure once you don't have a flow or the flow decompresses. So that is one way of knowing that your pressures were high. Other thing is, since we don't have real measures, the gravity related finger flow, finger touch, how much it can hit you on your finger, that is a very crude way, but I think there is no better way than us knowing how much the force of water touches you. I like the pumps where I can control the flow, obviously. So we have a foot switch, and I can measure how much I want to deliver the fluid, the water inside. I can control the flow, I can control the pressure as well. When I say pressure, why do I say that? Because during the process, when I put the laser fiber into the working channel, it is the same passage through which the water goes in. So if I use the pump, then pump pressure a little bit to keep my vision good, at the same time having a very good return. So what it helps me is the vision remains better even with the laser fiber occupying the working channel. So good irrigation is necessary. It improves the vision, and obviously it does not allow the laser heat, and that might be theoretically or practically causing damage. There is a good article in the recent AUA Journal of Urology from the Greece group, Dr. Liatsikos and group, who has talked about this part as well. Now coming to the most important part, the flexible ureteroscope itself, reusable versus the disposable. Now, if you are working in a very rich center where people are not going to question you for breaking a reusable scope. Now, let me give you an example. I work in a private setup. It's a business oriented model. And we know that, I mean, I can just say that in dirhams, which is, you can compare later, one reusable scope, which is a digital reusable scope, like for example, Flex XC, would cost somewhere around 125,000 AED, that is the dirhams. Now you can compare your own cost, and I'm sure everybody knows the digital scopes are costlier. The fiber optics, they compromise a lot on vision. So there are lots of pros and cons to be discussed. But when the disposable came into picture, when the disposable came in use since last 2.5 to 3 years, almost all cases, wherever possible, especially the larger stones, I've been using disposable. So what are the advantages? So larger stones, you can spend longer time. There is a risk to the damage of not only the fiber, the heat, the laser fiber having an issue, which they call as the laser injury to the scope. And at the same time, long time use causes the flexion injury. So if not in one case, in a second long case, in the third long case, your reusable flexion part will get deformed. So what will happen is you might not be able to reach certain chalasis after a few procedures in the reusable ones. Now, obviously, disposable, you don't have to think about it. 1 point in favor of disposable. Reusable scopes are delicate. We know that. Fiber optic, they have their visual problems. They are delicate. We have to attach a camera. So you cannot work for a long time with such a heavy thing in your hand. So you invest in a digital scope, which is reusable, and it is costly. And maybe in the 10th case or 20th case or maybe 35 cases, you would, as the literature says, that is what the average is. I'm sure every urologist, every endourologist will have his own good reusable scope, which can last maybe 60, 70, maybe 100. We had one which lasted 100, even with 3 people using those scopes. So, but disposable, you don't need to worry about that. Especially when the chip-on-tip technology, obviously, which has come, the vision is not as bad as the fiber optic, and it goes very close to the actual, say, the common reusable digital ones, the more sophisticated ones. But there is no fear. We don't fear that I will break the scope. If it breaks, it breaks. You can sometimes even still continue working. So there you find an increased success in these larger stones with single use, that is the disposable scopes. Basically, endourologists will not feel afraid of that inadvertent damage sometimes that by mistake the fiber came in or came out. Everybody, or there are not very real robust mechanisms where the fiber is secured best that it will not. There are locks available, yes, but everything adds to the cost as well. The laser locks which don't allow the fiber to go in and out. So that there are options for that as well. Disposables on a longer note, as Dr. Wissam said, that they have become more available, more companies making, so the competition reduces the cost. And as you do more and more cases, the cost automatically comes down rather than spending more on the repairs, spending time without the reusable scope. So ultimately, at the end of the day, if you do a math of say 1,000 cases or 500 cases, you might end up actually saving more if you use disposables, disposable ureteroscopes. With experience, obviously, when you start using more, your vision becomes, you become adapted to the vision, the monitors, and your stone-free rate improves. Overall, yes, that is what we want, better stone clearance. If we can achieve in stone one single sitting, wow, that will be really good. And to be honest, it is possible. The dust and go technology, the good laser, the good irrigation, the good flexible ureteroscope, the good one being disposable. Now, usually ureteroscope is our daycare, most parts of the world. So the saving part of the money saving part also comes by a person going back to the work early rather than keeping him in the hospital with PCNL for maybe 2 days, maybe 3 days. Some people still like to put nephrostomies. So there are obviously, for this 2 to 4 segment, the 2 to 4 stone segment, disposable scopes are going to be really good. And we see that the readmission rate, which is classically the 30 days readmission rate, is very low. What are the risks with RIRS? So whether we use flexible or maybe disposable, but I will explain why disposable helps again in complex RIRS, where Dr. Wissam showed how multiple twisting happens to the flexible ureteroscope. And I don't want that to happen to my Flex XC in the 3rd or the 4th case. And then maybe I cannot use it because it no more deflects. The deflection mechanism fails. Additionally, there will be in some infundibular stenosis, there will be severe acute angles, as I mentioned earlier. There are cases reported from RIRS as pseudoaneurysms. So it is not unheard of. Anything when we use lasers, when we use even DJ stentings, there is actually a paper by Dr. Buchholz who reported a case where even a stent insertion, which don't know a reason why the patient developed a pseudoaneurysm. Very important not to operate in a proven UTI. Yes, but still when you open up the infundibulum, you go to the access for the stone. I don't know how many people really use the laser to, in the ablative mode, to open in the right space or the right fibrosis, the infundibular stenosis, to get access to the stone which is behind. So this is a competition to the ultra mini PCNL, where they say that it is a obstructed cheilitis, infundibular stenosis, and we cannot do. So disposable scopes practically helps to reach you there, and then the good laser helps you to open that infundibulum. 12 by 14 access sheet. I don't think over the last 3 years I have faced much of a ureteric injury issue on an immediate complication nature. At the same time, the patients following up with me every 6 months to 1 year, which I make sure they come for some evaluation. So there is no ureteric stenosis or a stricture developing by the use of 12 by 14 sheath. So another important aspect of the staging procedures. So talk and explain to the patient. Explain what success means. Stone dusting, stone fragmentation is a part of a success. Our target less than the size of the laser fiber diameter. So we internally, when we visually analyze, I compare and try to get the fragments. If not, dusting not possible. It is not always possible in larger stones. So you break and really break it as small as possible to maybe half the size of the laser fiber diameter. DJ stent, yes, it is the lifeline. You might need to keep the DJ stent longer. I many times extend it to 4 to 6 weeks. And once the patient is talked about, once he is explained, he accepts it more easily. You might see the dust or the stone. So this, when explained to the patient, actually the patient feels nice. Oh, doctor, yes, I saw in the next visit. After 2 weeks, the patient says, I saw a good amount of particles coming out. My pain is also reduced. These are some good testimonials that you hear. And overall, that is where 2 to 4 centimeters, you challenge yourself and you take up the challenge. Need for second procedure for sure has to be explained. There is no question about that. And this we need to explain for PCNL as well. We need to explain for shockwave lithotripsy as well. So why not for RIRS? It's not a crime. Why RIRS should not be saying that, okay, we might do it second time. Additionally, if you have your fragments which are bigger, sometimes they form the Steinstrasse. This, when talk to the patient, he will come for a follow-up. Usually I do a 7-day and a 15-day follow-up. And if the patient is additionally complaining of pain, and then we do a plain simple X-ray. And if it helps to find out a Steinstrasse, then you intervene maybe earlier to do a rigid ureteroscopy and the extraction of those pieces. And that is relatively a simpler procedure, and patient accepts it well. Maybe we reintroduce it, we replace the old stent with a new stent, and we another 3 to 4 weeks later, that is what we practice, and patients are very fine with that because they come daycare and they go away. Second procedure does not mean a failure. So my suggestions towards the whole topic of RIRS for larger stones, 2 to 4 centimeters, that what I would do, and that my experience, and I'm just suggesting a few things. Laser, know your laser. Best settings for dusting and rapid fragmentation, you find yourself, do the adjustments in the laser, because the company is not going to be as good as you after some days when you start using your laser. Whatever machine you have, know it better, do those fine tunings. Irrigation pump with the pressure and flow, personal experience, controlled flow, the vision is better, foot switch, the assistant feels involved, no vision available, press the foot switch, pump irrigates, and there is a good synchronized ballet dance going on for working. Ureteral gripping, and that is our fingers. When we calibrate, and if we cannot put the 12-14, I would lay a lot of emphasis on 12-14 for stones which are 2 to 4 centimeters. So when you do this, I would not recommend, I would not do personally, I am not done using 10-12 sheath, because I want to work longer, I want to break longer, I want to have good irrigation. So I want to have a good, very low intrarenal pressure as much as I can, because I cannot really measure, there is no technique yet available. So it is good to have a larger sheath with good backflow. And to be honest, you will many a time see, while you are irrigating it well, you will see a lot of dust gathering at the end of the white part of your access sheath. And I'm sure everybody has experienced that. Perform ureteral calibration. Optical technique is the best technique. If you have those serial ureteral dilators, I would suggest you try, and I'm sure you will soon become a fan of that, because I try to use it almost always, because our fingers are the best feelers. When we feel it, that it is not going easily, you can stop and you can stage the procedure, which the patient has already been explained. As I said earlier, 12-14 access sheath is to be used for 2 to 4 centimeter stones. Even if we get the scope which is getting smaller, the disposable scope, as the PUSEN is going to come forward with the smaller scope, it will be still better. You use 12-14 and you use good irrigation and use the smaller scope. You have a better irrigation, lower intrarenal pressure, longer operating time. And obviously the patient has to be extremely well informed. He should feel that he knows how to do the surgery. He should be that well informed. And yes, as the literature has already suggested, that we use medical expulsion therapy for all these patients post-operatively. So you start, sometimes I give alpha blockers as well as anticholinergics, and they work. Even the physical exercising and quick back to work, all these principles with good amount of water intake, motivation to the patient, it helps. And you can use the least invasive procedure for even the largest stones. So I'm just going to show a video which is kind of just showing the dusting part. As you can see, this is the PUSEN monitor. I like the PUSEN monitor instead of connecting it to the direct. This was another patient, as you can see. Are you able to see the video, sir?
Yes, we are. View
Yes.
is amazing, clear.
And the last part, which is the most important part, I might show it twice, is this is the 1214 access sheet with the PUSEN inside, with the flow not more than 250 ml, 250 to 3 ml per minute. Our machine shows a particular pressure system, but we don't really know what the intrarenal pressure is because nobody can measure that. But I am glad that I see such a good flow, and I know that the pressure inside is less. So this is one thing which I wanted to show as a practical point. Look at the EAU guidelines 2020, and I want to read this verbatim, quote unquote. Recent clinical experience has suggested a higher stone-free rate of RIRS compared to shockwave lithotripsy, but at the expense of greater invasiveness. So that comparison is between shockwave lithotripsy and RIRS as invasiveness. Depending on operator scales, stones up to 3 centimeters. So already the guidelines are changing. Can be treated by RIRS. However, yes, stage procedures. Stage procedures, lesser invasive procedures, I don't think the patients are going to mind that. So in our center, although being not a very academic center, we are trying. We have collected the data for last 3 years. Our single center data is maturing for publication, and I hope we will soon be able to publish it. But as I have written here, maybe soon we will see the shift in recommendations, more stronger recommendations for maybe not only RIRS, but they might even say that disposables are more better to use in larger stones. And that is what I do. In my practice, if it is a 1.5 centimeter stone or a 1 centimeter stone, which I plan for RIRS or smaller than 2, then I use the more costly, the reusable scope. I'm going to spend less time. It would be more quicker. But if I'm going to do the more bigger stone, then I'm not going to use the reusable, the costlier one. I'm going to use the disposable one. And I have given my patients good satisfaction. They are satisfied of even in the stage procedures, which currently I should say it is roughly around 15% of the patients who need a procedure, which includes just the extraction of the stone. And just to provoke the audience in terms of just changing the nomenclature, twisting a little bit, we are using an access sheath. We are breaking the stones inside the kidney. Why not it be called a per urethral laser nephrolithotomy, just for people who like PCNL as the name. So why not PUNL? Thank you very much for your time.
Thank you very much, Dr. Pandai. It's for excellent presentation and very challenging putting the ureteroscope, both reusable and disposable ones, in the big stones more than 2 centimeters. It's really challenging for all of us, I think. So I like the video of the backflow of, from the access sheet when you were doing your breaking the stones, and while you were breaking the stones, you had those backflow. So it's give you a sense of that there shouldn't be that much pressure intrarenally, so that you can work. So, but still, as it's mentioned, it will be nice that not only academically we have intrarenal pressure measured, even clinically, if we have it, it will be a very important tool for us. And I think the secret, yes,
this
please.
challenge might go to the companies who
Yes.
make scopes to have some form of sensors at the tip. I am sure they are working on it.
Or the access sheet that has one of this.
Or even
And
the scope itself, because
yes, exactly.
that would.
So I think we are moving towards a smaller caliber flexibles, and as you mentioned, as you were emphasizing on 1214 access sheet in order to reduce the intrarenal pressure, of course, then a better vision, and the time that you will work will be you can do it longer. So that will take us to the first question from the audience, is saying that normally how long those flexible, you are using the flexible URS surgery will take time for breaking a stone more than 2 centimeters. And will you fragment or you dust, and whether you will use the pre-stent before the procedure.
So my take on this question is, once we do the flexible ureteroscopy and once we see the stone, we kind of know whether it is a soft stone, medium soft stone, a medium hard stone, or a very hard stone. Usually, the larger stones will have a core which is very hard, and there will be softer part on the outside. So 2 to 3 centimeters, 3 to 3.5, 3.5 to 4 centimeter stones. When you know your laser well, when you see the stone, that is the time that I decided whether I will fragment the stone or whether I will dust the stone. And the moment first I will start with the dusting. When I start dusting, you know the nature of the stone, because the stone declares the surface, declares itself that I am soft once you touch the laser. So the visual effect and your experience will tell you whether to continue till you need a larger energy source, or you need to crank up the energy to break the harder part of the stone. So typically, as we know, low energy, high frequency is dusting. Do it till you reach the harder part of the stone. This is what is going to happen during working on larger stones. So practically, what I would say is, know your laser, use a larger access sheet. I will just repeat the suggestions that I did earlier. The reason is because you have to fine tune at every moment of the whole thing. If the stone is really very hard entirely, I would not go more than 90 minutes, sometimes to 120 minutes, because my backflow, and in fact, they keep on telling me the amount of fluid used as well as the amount of coming out. That is what we have a collection chamber. We have a measuring bucket. So that is measured as well. So the inflow and the outflow. This is what all done when we are using, we are challenging ourselves with this large stone. So probably that answers the question in terms of the fact that larger stones will not have a fixed fitting. This is customize your methods to give a good stone free rate. And I would say more than 50 to 60% of the times, especially if you are lucky and the stone is soft, you might finish it within 1 hour. It may be a 3 centimeter stone or a 3.5 centimeter stone.
And are you pre-stenting? The last part of the question.
No, there is no pre-stenting because being a private setup, what happens is we don't have residents. Pre-stenting, I have seen, it is more in situations where there are residents, where they see patients at night or they take in the patient and then they stent. Usually, if you see upfront a cold case, I don't think anybody does pre-stenting unless you go in, you see that everything is so tight, the ureter is not pliable, it is not allowing entry, then it turns into a pre-stenting. We don't do a pre-stenting.
Yeah, but this will take us to, I will skip the next, because there are some questions that are related, talking about the 1214. So since you are emphasizing on 1214, and it's not easy to pass this in majority of our patients. So they are emphasizing whether in their experience, the pre-stenting probably will be in those cases will help better. What do you think?
I totally agree to that. If you want to do RIRS for a larger stone, say let us put 3 centimeters as the limit for discussion today. And if you want to challenge yourself with this 2 to 3 centimeters and don't want to do a PCNL for this kind of a small stone, I think 3 centimeters or small is a little bit overkill for PCNL. There are so many experts in the world about PCNL. I do PCNLs myself. I do a lot of laparoscopic stone surgeries as well, where I introduce the flexible cystoscope and extract the stones from the calyces as well during laparoscopy. So pylolithotomies with intrarenal, actually I presented that one in a conference in Oman as well as in Japan. Now, the whole idea is that if I'm going to do 2 to 3 centimeter, I'm going to challenge my laser, I'm going to challenge my ability to break the stone and give a day care satisfaction, minimal invasive or rather lesser invasive, then no harm. Inform the patient. Take him in your team. Make him feel that he is the most important decision maker, and if he understands that you will pre-stent, then he will say, okay, doctor, no problem. I will go with the stent for 3 weeks or maybe 4 weeks or 2 weeks. It is your personal choice. And usually when the patient comes back, you are 12-14 sheath, you don't even need to calibrate. You remove the stent, put the wire, put the black part of the sheath or the inner sheath first, and the access sheath will walk in. I'm sure all of you might have had that experience, especially with the pre-stented.
Thank you for answering that. Next question is, what is the length of the ureteral access sheet that you're using, and where you will put it in relation to the PUJ?
This is an excellent question. Now, not always. So first of all, I like the shorter access sheet. I don't like the long ones, because the longer ones have a lot of redundant access sheet outside, which makes your re-entry and doing things difficult, and it wastes a lot of time. There is a lot of flippy floppy nature of the longer access sheet. So I use the shorter access sheet, which practically, if I can place it without injury to the UPJ, I will go as much as possible. If not,
regardless the gender?
Regardless the gender?
Yeah, male, female?
Yes, absolutely.
Okay.
I have not found a big difference, especially if it goes. So that is why calibration is important. And if you feel that the calibration exercise has given you the confidence that the 13 or 14 French calibrating instrument, which I showed the serial dilator, if it has gone in, and I don't stop. I stop only if it doesn't allow my fingers, when my fingers feel that it is hard, it is going to maybe tear something, then I don't push. Then I check on the fluoro and I see where it is. I mark that point and I will not put the sheath beyond that. Now the proximal part of the ureter, which is anyways going to dilate with the irrigation, no harm. You go in through that residual part, the balanced part of the ureter, it is an entry without the sheath. But keeping the access sheath, ultimately it allows, still it will allow a low pressure, because your irrigation is not having an obstruction.
So
additionally,
so the message here is very clear, that you prefer to use the short access sheet, because even if you stop in any part of the ureter, then you leave it as it is there, and then you can go as an entry and exit. You can use it and reducing the intrarenal pressure. Well taken. The next question is asking about any difference in ureteric caliber between the male and female.
Rather than the male and female, I feel there is a geographical variation that we find, because the countries that we work, we get patients from the Middle East, we get patients from India, Indian subcontinent, we get patients from the Caucasian countries, the Europe as well. So as for the first part, male to female, I really don't really worry much. I just calibrate the ureter. If it goes, whether it is male or female, it should reach till it reaches safely without my fingers feeling that I'm tearing something, which is the most important part. The problem comes when we see a lot of very small statured, many from Indian subcontinent. And I talk to my friends from India as well, who are now increasingly doing flexible ureteroscopies. They say that 12-14 is hard. But in India, the way it is, or Indian subcontinent, they have a different mathematics of everything. So it is not many times comparable to the rest of the world. But yes, I find that the origin of the nationality sometimes plays an important role, and you can expect that I expect sometimes that if it is a small man from India or Bangladesh, then the sheath 12-14 may not go. So I tell them specially that you will need to have a stage procedure.
Thank you. Next question is, it's a very sensitive question, by the way. It's saying, is it possible to reuse the disposable flexible URS? I'll leave the answer to you.
If you are in a country
Dr.
where...
Wissam also can share if he would like to.
Yes, Dr. Wissam, do you want to start with it? Because I have a particular say on that.
Okay, so it's interestingly, I think during the World Congress of Urology, the last one, which was conducted in 2019 in Abu Dhabi, I found out that many do it but don't admit it. So, so it's I thought it's not a general practice, but I found that it is a general practice all over. But I think it depends a lot about your center and what you can do, because the main idea behind using a disposable flexible ureteroscopy is to reduce the risk of infection. So if you sterilize it, I don't know how much it works, this kind of reducing the infection. And if you did it, I think you agree with me that after sterilization, especially if you went for SSD, the efficiency of the scope is not the same. Because the material is not as durable as regarding
for
the sterilization.
reusing it. Exactly.
Exactly. Like the reusable.
Yeah, thank you very much for this answer. What about you, Dr. Pandey?
My view on this point is, as Dr. Wissam said, if you belong to an environment where this is not considered illegal, you might not be questioned by the medical authorities. Your answerability is not. So if you have a good rapport with the type of patients that you have, and if you won't fall under the scanner of the legal systems, there is no harm doing it. Only thing is, as Dr. Wissam again said, that reusing this sterilization causes kind of a thermal damage or whatever the damage may be. Now, at the end of the day, if I can use one disposable scope for 5 cases, it is better than breaking one reusable scope after 30 cases. So I am breaking a disposable scope on purpose after 5 cases, which is mathematically saving a lot of resource as well, and not needing those repair issues. Yes, suppose you take the reusable scope, the disposable scope, which is sterilized, and you start working and it conks off. Suddenly it will just go away.
Yeah.
And just open the new one. So that is the advantage of...
So the answer is no. I think majority of those reusable, they have a special system, like in Boston. You can use it only once. Once you plug to the system, it's then it will you cannot reuse it for the safety. It is stopped. Some of the other scopes, the disposable ones, or single use, they have a limit of time period. They use it for 4 hours and then that's it. You cannot use it. And all of this, I think, for the safety. As Dr. Wissam mentioned, those materials is made for using for a certain time period, certain period of one case. And really sterilizing can damage those that will put safety of patient in danger, I think. The last question is asking about, do you experience the situation where you had a difficulty on retrieving the access sheet out? And what do you suggest for those situations? So any of our speakers had this experience that the access sheet is stuck and it's not coming out?
Can I answer first?
Yes, please go ahead.
So the situations where I would expect this to happen is when my introduction was hard. And then if I am going on for a very long time, then I would expect the ureter to have some form of edema and increasing grip onto the 12-14.
So the entry shouldn't have been done from the first time.
Exactly.
Okay.
So again, our fingers are the most important things.
Okay.
We have to develop that experience, especially for when you are challenging yourself to do the larger stones. The second problem that can occur during this, why it can occur, is if your ureter is compliant, still there will be some stone particles will come around the sheath with the flow. And that would maybe grasp and not allow. Sometimes you know how the DJ stand in a Steinstrasse or those kind of things. Now, that is where good irrigation is going to help. And under vision extraction. So you keep the flexible scope at the end of the sheath, give a good irrigation. So let the ureter dilate, and during the irrigation, you are pulling everything under vision. So your tip of the flexible scope is sitting at the edge of the tip of the sheath. And that is where these things might get, if that happens, you might be able to resolve the situation. Sometimes maybe just remove the scope, put some jelly, go back inside. Anything more for Dr. Wissam, you can please add.
Yeah, Dr.
I
Wissam,
can surely agree. Yeah, regarding that, I never fished it because I never force it, and this is what I tell my resident. You know, it's it's better to lose the battle than to lose the war. And this is what I tell my resident. If you couldn't introduce the ureteral accessory, you couldn't do ureteroscopy, just send the patient and bring him another day. Don't force the insertion of the ureteral accessory. If you have a problem, introducing it, you will have a difficulty in getting it out. And sometimes the same thing about reusing the disposable ureteroscope. In some centers, they reuse the ureteral access sheet. So the hydrophilicity and the ureteral access sheet itself, with the sterilization, it loses the hydrophilicity, the hydrophilic coating, and this might cause a problem. So this is another problem of reusing the disposable material, and I wouldn't recommend that, especially in the access sheet.
Just to share my experience, I had a situation, and the majority of the cases is because of the entry. If you had a difficult entry, probably you will have a difficult on coming out, or if the stone have a stuck between the ureter and the access sheet. So if it is just you're retrieving once with the basket, once you reach to the entry, then you lose it, and it will go and will stuck between the mucosa and the access sheet. And I had a situation like this, and it's a very difficult situation, and you might have an avulsion if you pull it in a wrong way. One of the things that experience showed retrieving it in a turning. So you turn and you centimeter by centimeter, you turn and you retrieve, turn and you retrieve in order not to avulse, and keeping a guide wire through this. So you have a safety guide wire out and you put another guide wire in. So this will push more and make the tensile of the ureter higher so that you can retrieve it. So just to share with the other this experience. And it's a very difficult situation. So I think we come to the end of this session. Really, I myself have enjoyed this meeting, learned a lot of challenges, and we have two eminent speakers who took us through very challenging about the stones that now we are tackling the big stones. It's not a matter of using the flexible, the reusable versus the disposable or single use. Now we are entering a new era of using those in a big stones, and there has its own challenges. What we have learned here, always use as much as possible, use the bigger access sheet, and as much as possible, smaller caliber flexibles in order to have reduce the intrarenal pressure, and of course, limit yourself with the time of the surgery and use those ABC in order to be safe. I would like to thank here our speakers and the PUSEN Medical for allowing us to share our experience with the other colleagues. And I would like to say goodbye and have a good night, everybody. Thank you.
Thank
Thank
you.
you, Dr. Shamsuddini. It was a pleasure. Thank you, Dr. Pandai. I enjoyed your presentation thoroughly. And thanks for PUSEN for allowing this opportunity. And I hope to see you in person soon.
Thank you very
To
much.
have you all on the group.
Thank you
Thank
very
you.
much. Goodbye. Goodbye.
Bye.